Good evening. Tonight we're going to be doing some Ask Me Anything. There's some great questions about the endothelial function. That's what I was doing this past weekend, was actually teaching some doctors in Chicago about the endothelium and the glycocalyx. So I'll teach you what I taught them. So welcome everybody, and we'll get started. So the first question tonight, do I think that aged garlic supplements help with arterial plaque in any way? Thank you. So yes, I believe the Kyloe aged garlic is helpful for help stabilizing plaque. There's been studies done in patients with elevated CT coronary calcium scores out at UCLA, and it does help stabilize the soft plaques. Garlic is anti-inflammatory, prevents the LDL from oxidizing, helps lower blood pressure. So it's one of my mainstays in people who have plaque to help stabilize the plaque. But you want to go for the Kyloe aged garlic. Got some photobiomodulation questions tonight. So somebody's asking, can you get too much red light therapy? Excuse me. And what's the best time today to do red light? Answer the second part first. So generally my recommendation would be to do it during daylight hours. You're trying to use it as a supplement, recreate what Mother Nature intended. So some people are more sensitive to this light therapy at nighttime. It's more the intensity of the light than it is the wavelength, and may affect their sleep onset. Red light therapy can release melatonin from the mitochondria, but still the bright light might affect your sleep. So generally use it during daylight hours. But back to the first part, can you get too much red light therapy? Absolutely. That's what's known as the biphasic response. So, no light therapy, no benefit. Too much light therapy, you basically overcharge the circuit and you will lose the benefit. Rarely do you actually get into the harm effect. But there is a sweet spot. So it's the recipe, it's the irradiance and the time that gives you the dose. Next question about the red light is, do I bring a red light device when I travel? Any problems with TSA at the airport? So it depends on where I'm traveling. When I travel international and I bring one of my laser watches with me, I almost always get stopped. So I don't typically want to bring those with me because I don't like being drugged to the side and asking what this is. But if some of my CareWear patches, nobody's ever bothered me with those. And sometimes I bring kind of the smaller brick red light panels, nobody's ever bothered me with those either. And sometimes I'll use the bricks as just kind of a task lighting in a hotel room. And I do travel with it's a Gimba red LED bulb that you can screw into the standard light sockets. So if you have access to the light socket, then I at least switch one of the lamps out at a hotel room so the room can be red at nighttime. So back to a lipoprotein question. So I answered this question with some patients earlier today. The question is about hyperabsorption on a cholesterol balance test. This is a test that's found on the Boston Heart Lab panel. So sterols, you can either be a hyperproducer of sterols, or you can be a hyperabsorber, or you can be both. But if you're a hyperabsorber and you're bringing back a lot of beta-cytosterol, then that means the Niemann C1-PIC-like receptor in the gut is basically stuck open, and those sterols are coming right back to the liver, and your body's making more lipoproteins to ferry that cholesterol that your body had made and was trying to get rid of. It's going to have to transport it around the blood vessels again and try to get rid of it. So in that instance, I would generally recommend the ezetimibe, or Zetia was its brand name. The statin depends on if you have significant atherosclerosis or if you're also a hyperproducer. Statins work more by decreasing steroid production in the liver, so the LDL receptor has to come up and grab more of the cholesterol particles out of circulation to repopulate the cholesterol that the liver is not making. So often we'll use both, or sometimes ezetimibe alone, but it sort of depends on what the risk is for that patient. If it's secondary prevention, person's had a heart attack, stroke, stents, bypass, probably would use both right off the bat. If it's more primary prevention, and the person is either hesitant to be on statin therapy, maybe we'd start ezetimibe and 90 days later recheck the panel and see where things are at. Make sure that the hyperabsorption has recovered, and then see if your ApoB is at goal. If your ApoB is generally under 70, then maybe you get away with just ezetimibe. Otherwise, maybe you add low dose rosuvastatin, 5 milligrams twice a week, 10 milligrams twice a week, and see where you're at then. Next question about what foods naturally improve the endothelium. So I would use more of the term of like what is going to support healthy nitric oxide levels that then can help protect the endothelium. So the lifestyle things that can help, always start with the free ones. So this is where, UVA sunlight hitting your skin is going to liberate nitrates from the blood vessels. You didn't ask about exercise, but exercise is one of the better things that release nitric oxide with the shear stress going across the glycocalyx, stimulating the endothelium to release nitric oxide. But from foodstuffs, it's generally going to be the nitrate-rich foods. So that's mostly the dark green leafy vegetables, the spinach, the kale, the arugula, and beets. But the caveat is, and I learned this from Dr. Nathan Bryan, who's one of the world's experts on nitric oxide physiology, is that organic foods will have less nitrates in them. And you will probably not be able to eat enough organic food to get your nitrate bolus for the day, which generally has to be 300 milligrams. So you generally, if you have low nitrate rich foods, you're probably going to have to supplement those then. And there's multiple different supplement companies that provide the proper dose of nitrates that can become nitric oxide. Similar line of questioning is, if the endothelium is damaged, can it be repaired? So the talk I gave at the functional forum this week to a bunch of physicians was that you want to first think about the endothelial glycocalyx, which protects the endothelium. Because if that becomes damaged, then all the downstream effects, the oxidation, the inflammation, the autoimmune dysregulation is going to occur, and the endothelium is going to get impaired and damaged. So think about the glycocalyx. So lower oxidative stress, lower inflammation, lower lipoproteins. That's kind of the starting point. And then there are different things that can help support the glycocalyx. There's at least 3 companies that make products that support the glycocalyx function, basically give the glycocalyx building blocks. And then, if you have issues with glucose, you probably want to consider something like metformin or berberine to become more insulin sensitive, because high insulin, high glucose damage the glycocalyx. So yes, it can be repaired. It's easy to damage, but it is easy for the most part to repair. All right. Next question up tonight. What are the reasons to look into fatigue in people above 75? So, unless I wouldn't limit it to somebody over 75, but fatigue is a common complaint for primary care physicians and often cardiologists as well. It's often multifactorial, but if I was just going off the top of the head, do you have a thyroid issue? Are you subclinical or clinically hypothyroid? Are you anemic? Do you have enough red blood cells to ferry the oxygen and nutrients around the system? Are you hypogonadism if you're a man? Are you postmenopausal in a woman? Hormones play a role in fatigue. Do you sleep well? Do you sleep 7.5, 8 hours a night and feel well rested the next day? If not, then you may have to look into optimizing your sleep. Do you have sleep apnea? Do you need to get a sleep study to figure this part out? And then, kind of in the cardiology world, do you have a heart rhythm issue, atrial fibrillation? Do you have a weak heart, a cardiomyopathy? Do you have a diastolic heart failure where the heart is not relaxing well? Do you have coronary artery disease? Blockages in the arteries stealing nutrients from the heart, and sometimes that's their anginal equivalent. They may not have the elephant pressing on their chest symptoms. They have the shortness of breath, fatigue type of symptoms. So a lot of things that can drive it, but a good physical exam and history can kind of get to the point of when did you last feel well, and then what's been going on in your environment that may not be keeping you optimal. Another lipoprotein question tonight. Do older people who have high LDLs and metabolically fit live longer? So, can't really answer the question just based off those 2 data points. And you also would have to define truly what is metabolically fit. If it just means you have low triglycerides and high HDL and your A1C is not above 5.7, that doesn't necessarily ensure you're truly metabolically fit. And then high LDL, well, I'd actually want to know, do you have high ApoB or high LDL particle? That's much more better predictor of atherosclerotic risk than LDL-C per se. You also did mention, do you have atherosclerosis? If you have significant atherosclerosis, then having high LDL by itself is probably going to lead to you having more events. So do they on average live longer and they're metabolically fit? Possibly, but you'd have to define metabolically fit and what is really going on with the arteries before determining if, quote, high LDL is a problem or not for this person. What test do I recommend a person should take to check on overall heart health? Great question. It always will slightly depend on your age when you start checking. The other week, I had seen some children of some of our patients who are in their 50s, and they wanted their 30-year-old kids checked out to figure out did they have any genetic abnormalities that put them at increased risk of early atherosclerosis. So we did a different type of panel for people in their 30s than in their 50s or 60s. But you always want to start with testing that looks at endothelial health and a surrogate for kind of the glycocalyx health, because you can't directly visualize the glycocalyx yet, at least in the heart. You can visualize it with intravital microscopes, but maybe that's not truly ready for clinical prime time just yet. So you got to look at some surrogates. And you can look at, tests that look at pulse wave velocity. There's some consumer-facing devices. I have some of them. They're decent, but not always that accurate at picking up, so sometimes you get some false readings with them. In the office, we have a device that looks at pulse wave velocity called the Max Pulse, clips to your finger, looks at the blood flow in the small blood vessels as the blood comes out of your heart, goes in those arteries. If the arteries are healthy, they're going to expand and contract very quickly. Probably we want it to be like an accordion that's snapping back very quickly. You don't want your arteries to be a lead pipe. So this will give you a wave type score. The lower the score, the better. 1 and 2 are optimal, 6, 7, arteries very stiff. There's also tests that look at carotid intimal medial thickness. Almost anybody over the age of 30 could consider this test. It's likely skewed that it's not going to tell you that your biological age is younger than you are at that point, but you just want to make sure your arteries are not significantly inflamed. Unlikely to develop a lot of plaque under the age of 40, but possible. And then depending on family history, you may want to look at coronary arteries before the age of 40, but for most time, you start looking at the coronary arteries with either CT coronary calcium scans or CT angiograms, after the age of 40 or so. Then the blood work, that can be done anytime. I mean, there's even studies that people are doing them in younger kids, that they should have their Lp(a) levels checked before they're, I believe it's at least 8 years old. I think maybe even below 2 years old, they might want some people to be checked. And then having just a baseline lipid profile in your single digits or teenage years to say what is the likelihood that you would have a genetic predisposition to high lipoproteins. Because if you have it high in your younger age, you can start treatment earlier and really lessen the risk of developing atherosclerosis in your 30s, 40s, and 50s. So that's where I would start with is testing a look at endothelial function, maybe some vascular testing with the CIMT, calcium score, and then a comprehensive blood work panel that looks at markers of endothelial function, nitric oxide availability, oxidative stress, inflammation, and lipoproteins. Then, depending on family history, the genetics that put you at earlier risk of early vascular disease. All right, so somebody's giving me some feedback. Thank you. Please write a book about all this. Let's just say it's on the back burner. It's on my mind. One of my friends, Dr. Gabrielle Lyon, her book came out last week. The book is Forever Strong. If you haven't picked up a copy yet, you can get it on Amazon. If they haven't stocked, they're out of stock briefly, but I think they're restocked this week. But you get on Barnes & Noble and your local bookstore, and I believe even Target still has them in stock. But Dr. Lyon's book, it was 2 years in the making. So I have to, sit down and really think about, what I'd want to put out there that would not, in my world, be out of date by the time it hit print. So I usually try to stay as up to date on things as I can, and try to keep it as tactical and practical as I can. I don't want to write a encyclopedia that's going to be out of date in 2 years. I'd want to write stuff that's very tactical, like these are the testing you should ask your doctor for. These are the ways that you should consider optimizing your sleep. So being much more tactical. So I'm thinking about it. But if not, I'll be having more and more long-form videos on my YouTube channel to kind of augment these shorter form Q&As. So I think there's a two-part question. Somebody says that they suddenly start freezing, first their nose, feet, their legs, then their organs. Can it be heart related? Possibly, but I'd be more concerned that it'd be a thyroid function issue first. It could be microvascular disease. 99% of your blood vessels are smaller than the diameter of your hair. So if you have low nitric oxide availability and stiff arteries and not providing blood flow and nutrients to the tissues, you're going to get these kind of Raynaud's type symptoms. So possibly is related, but would need it to be examined on physical exam and then doing the right blood testing to confirm. I think the add-on thing was that the person said that they had a heart attack and they've had heart failure 10 months ago, with blood pressure normal, pulses in the 80s. So hemodynamically stable, but still doesn't mean they don't have microvascular disease. If you've had a heart attack, you need to know why that would have happened. Often it's a plaque rupture, but sometimes it's a plaque ulceration, or it's a spontaneous coronary dissection, or it's a type 2 MI where your body doesn't have enough oxygen nutrients and the tissues die. So there's a lot of reasons for heart attack. Most common is a plaque rupture. And heart failure can either be systolic or diastolic. So is the heart not squeezing well, or is the heart not relaxing well, or a combination of both? But if you have heart failure, you have mitochondrial dysfunction, and mitochondrial dysfunction, you have an energy production issue. So that definitely could be a heart-related thing causing some of the temperature regulation issues. Another red light question tonight. What to look for in a red light option? Are they all the same? Person's based in Ireland. So thank you for the question. Start off with first, no, they're not all the same. And that's still somewhat the challenge, is it's sort of the Wild West out there on Amazon and the web on marketing claims for some of these devices. The first thing is that you want to know what irradiance the device has. That's going to be measured in milliwatts per centimeter squared. It's essentially how many photons of light are coming out of the device at any one time. Higher does not necessarily mean better. 100 milliwatts per centimeter squared is kind of the marketing claim most of these ones will say. But if they actually use the correct meters to measure them, they're much less intense than that. You probably only need 20 to 30 milliwatts per centimeter squared on the irradiance. The other number that you would look at is the color of light, the wavelengths. Often they're a combination of red and infrared. And so you need to look at the nanometers of light that the devices have. A common red light wavelength is 660 nanometers. A common infrared wavelength of light is usually 810 nanometers, sometimes 850 nanometers. The infrareds penetrate deeper, so they're a little bit more likely to reach into the bones. Then it's going to be size. Wherever the light is shining, you're going to get photonic absorption. So in my office at Apollo Cardiology in St. Louis, we have an 8-foot tall panel by a 4-foot wide panel. You stand in front of it and your entire body is irradiated at once. I also have panels at home that are smaller. I have a device that's about yay big, and I use it to kind of spot weld injuries, or just treat the sternum to activate stem cells. I have other devices that are more kind of like back of a door panel. I have watches that have infrared and red wavelengths of light. So it really depends on what form factor and what you're trying to do with it. Many times it's a musculoskeletal application, so if it's a small injury, small lights work. But if it's kind of something you're going to treat multiple areas of the body, maybe a larger panel would be useful for you. So I know it's sometimes confusing. I do have some videos on one of my websites where I've talked about different use cases for these lights. The website is redlightdoc.com, all one word, and has some links to some of the companies that I either have their devices and can vouch for that they work well, or I know the owners of the companies, and oftentimes I've done IG Lives with them before, and they are reachable if you have questions. So you always want to have kind of a company that stands behind their product and is transparent in the settings on their device. You don't want a literal black box that you don't know what you're shining yourself, because when it doesn't work for you, then you say like red light stuff doesn't work, but it's you have the wrong wavelength of light, you have the wrong irradiance, or you're just not using it in the right manner. All right, and then one last pre-formed question, let's say, and then I have a few pop-ups in the comments we'll answer. But somebody's asking, how can an oral/gum infection harm the heart? This is a great question. There's definitely an oral systemic link to heart disease. So if you have a oral infection, you have periodontal disease, you have a root canal that's infected, your 60,000 miles of blood vessels are going to be transporting different compounds of the immune system through the vascular system. Interleukins, cytokines will be high, TNF-alpha will be high. It's that inflammation that your body's using to take care of an infection here, and the blood vessels are getting injured as innocent bystanders. The glycocalyx will degrade in the presence of high oxidative stress and inflammation. So that's how it injures the heart. So if you see me in the office, it's on my intake questionnaire, like when's the last time you've seen your dentist? Do you have any ongoing oral issues? I've had a patient in the past, have a heart attack. When he came in and did the blood work, I had not seen the guy for a while. The blood work showed that he had some vascular inflammatory markers that are likely consistent with an oral infection. He saw his dentist, had some infected teeth, got taken care of, the inflammatory markers went away, has been heart attack free since that point. So it is definitely connected, and you can often find it by looking at different inflammatory markers in the blood, but nothing beats having a trained dentist look in the mouth and measure the pocket depths and make sure there's nothing that appears to be infected. All right, so I think I got through all your guys' pre-submitted questions, so thank you very much. Those were great. It's always nice when there's a combination of some biohacking red light ones, some lipid ones, some ones that I'm talking about mitochondrial function, so those are always great. All right, so I have a question here. What could be causing chronic chest pain if the cardiology ran an EKG, ultrasound, event monitor, blood work, and say everything is okay? Well, that's generally the standard of care, but that does not mean everything's okay if you're still having symptoms. It does not necessarily mean it's the heart, but you want to do testing that looks at the microvascular circulation. The max pulse and endopad tests can look at that. Those look at nitric oxide availability. And then, a stress test, well, you can easily pass. I'm sorry, I don't actually see a stress test there, but stress tests typically only going to be abnormal if you have a 70% blockage in one of the arteries, but a stress test would be utilized to see can they recreate the chest pains. But you may want to do something that actually non-invasively looks at the arteries. So if the symptoms are still ongoing, considering a CT coronary angiogram, if you have normal kidneys, no issues with contrast, allergies, that's something to consider. But if you're not getting to the root cause, keep seeking. There's other doctors that will help you try to find what's causing your symptoms. So somebody's saying that in the midst of having a virus/flu, can tachycardia take place? If so, is 8 hours tachycardia worrisome? That's the body's natural response to an infection, is tachycardia. You're increasing the cardiac output. A fever is going to increase your heart rate. So that's the normal response. And you don't necessarily want to be knocking down the fevers, because the fevers is helping kill the virus or the bacteria. So depending on how fast the tachycardia is, because tachycardia is anything really over 100 beats per minute. If you're under 120 beats a minute, that's your body just doing its thing. But if a virus kicks you into supraventricular tachycardia or atrial fibrillation, your heart rate's 150, 160, or 200, then that's more concerning. But short hours of tachycardia are not likely to be an issue. It's just the chronic tachycardia that can cause a tachycardia-induced cardiomyopathy or weak heart. All right. Oh, yeah, that's a good point. Definitely not the expert in this area, but I'll give it a shot, give my 2 cents. But somebody's asking about sauna use and attempting to conceive a child. They're seeing mixed research on impact on sperm quality, probably number. Sort of depends on why you're using sauna in the first place. If you're somebody who's using it because you have, high blood pressure, you have heavy metals you're trying to detoxify from, then it's probably best to keep going down those protocols. If you're just using saunas because you like it after working out, you gotta see what's more prioritizing. So if you're more wanting to focus on having kids, then probably need to avoid excessive high temperatures to the gonads, because that is what's going to impact sperm number and quality. So I can't tell you for sure to stop using it, but depends on why you're using it in the first place. But if there's not, so for the general public, if you're not trying to have a kid and you're not worried so much about sperm quality, generally you want sauna use 3 to 4 times a week, 20 minutes of a rolling sweat. Somebody's saying, when you have a low calcium score and on a statin, is the statin calcifying the cholesterol? In other words, is the statin pulling the cholesterol and calcifying, causing the plaque? No, the statin is not pulling in the cholesterol and causing the plaque. The way it goes down is that the glycocalyx, which is a protective gel coat lining the endothelium, which lines the 60,000 miles of blood vessels, that glycocalyx gets damaged in some manner. It looks kind of like seagrass floating at the bottom of the ocean. That seagrass gets damaged, then the lipoproteins, which are carrying the cholesterol, the white blood cells, they stick to the endothelium. They get retained in the artery wall. The artery wall swells, there's inflammation in the artery wall, and then plaque continues to build up as more and more lipoproteins get retained in the intima, much like fly paper. Those things get stuck there. They aggregate, stick together. White blood cells start engulfing that aggregated ApoB particle group. More and more plaque builds up. With statin use, the statins tend to cause the soft plaque, or what I kind of call the pimple plaque, that's more likely to rupture. It's that rupture of the plaque where the soft plaque, the white blood cells spill out to the bloodstream and the blood clots. Now you have 100% blockage, and you will have symptoms. You'll have a heart attack at that point. The body's attempt to stabilize the plaque is by putting fibrous, smooth muscle over the plaques and then also calcifying it. It's forming a scar in the artery. So statins often will cause the calcium score test to go up. It does not mean that you're having more plaque. It means you're taking the plaque that is not yet stable and calcifying it. So on a calcium score test, if your calcium score test comes back at, let's say, example, 100, it's the density that's getting measured, but ballpark, about 1/3 of your plaque is going to be calcified. 2/3 of it's going to be soft, and that's not going to be picked up on a calcium score test by itself. That's why often on some patients you'll recommend a CT angiogram to look at the soft plaque, because it's the soft plaque that tends to be more vulnerable. It's the soft plaque that's more likely to cause a heart attack. The hard plaque, if it builds up enough, it's kind of like an iceberg building up, and then the peak of the iceberg pokes out of the ocean surface, occludes flow in the artery, and then you have angina when you exercise, but does not tend to cause the plaques that rupture. Not possible that it could, but it's more the soft plaques that tend to do that. So the statin is not pulling cholesterol into the plaque per se, it's causing the calcified plaques to occur by delipidating, shrinking the soft plaques. But that's a very good question, and that's one that I have to educate patients often on, is because once your calcium score is over 0, you probably should stop checking it, because almost anything that you do is either going to cause the calcium score to be the same, but you don't know about the soft plaque, or you're taking the soft plaque and turning it into a calcified plaque, and the calcium score test goes up, and you get all worried you're getting worse. So it's not worth doing it once your score is over 0 for the most part. I think we got maybe to the end of the questions there. All right, so the bottom of the hour. So every Monday night, 6 p.m. Central Time, we're going to keep doing these Ask Me Anythings. And somebody asked me earlier about writing a book. Let's just say I'll put it on the back burner for the time being, but if I get enough upvotes for that, and you have ideas on what you want me to talk about, maybe drop me a DM sometime, and then I'll add it to the list of things I'll talk about if I ever write the book. But honestly, if I write the book, I think I actually would write a children's book first. I already have a working title for it. I would call it The Adventures of Mito Mike. I would teach kids how to keep their hearts healthy, keep people away from cardiologists like myself in their 40s, 50s, and 60s. Happy to work with patients when they're older, but if we teach the kids when they're teens and 20s, they don't end up using hospital-based systems in the middle of the night with heart attacks. And there's one last question I'll answer it, and then I'll let you guys go. Somebody's asking about, does folic acid cause heart disease if your body's unable to absorb it? It'd be very rare that you could not absorb folic acid, but it may be that you have a methylation issue and you need to actually be able to use the methylated folate and methylcobalamin to methylate the homocysteine back into methionine. So if you have low folate levels and low B12 and high homocysteine, then it's better to take a pre-methylated compound than trying to take just folic acid, because your body may lack the machinery to be able to make that work. So, all right. So, appreciate you guys' time and attention. I'll be back next Monday night, 6 p.m. Central Time, and you guys have a great week. But if you have anything you need in the interim, just shoot me a DM.